Chagas disease stands as one of medicine's most persistent and tragic paradoxes, representing both a remarkable scientific discovery and an ongoing public health catastrophe. Named after Carlos Chagas, the Brazilian physician who identified the causative organism, disease vector, and clinical manifestations in an extraordinary burst of scientific insight in 1909, this condition continues to afflict millions worldwide more than a century after its initial description. Also known as American trypanosomiasis, Chagas disease exemplifies how infectious diseases can transcend geographical boundaries while remaining deeply intertwined with poverty, social inequality, and inadequate healthcare infrastructure. The disease results from infection with Trypanosoma cruzi, a protozoan parasite transmitted primarily through blood-sucking triatomine insects colloquially known as kissing bugs, due to their tendency to bite humans around the face and mouth during sleep. What makes Chagas disease particularly insidious is its capacity for prolonged latency, allowing infected individuals to harbor the parasite for decades without obvious symptoms before developing potentially fatal cardiac or gastrointestinal complications. This silent progression has earned Chagas disease recognition as one of the world's most neglected tropical diseases, despite its significant impact on global health and economic productivity. The World Health Organization estimates that 6 to 7 million people worldwide carry the infection, with annual deaths numbering between 10 and 12,000. These figures likely underrepresent the true burden, as many cases remain undiagnosed due to limited healthcare access in endemic regions and lack of awareness among healthcare providers in non-endemic areas. Historical context and scientific discovery. The story of Chagas disease begins in the early 20th century when Carlos Chagas, working in the remote Brazilian town of Laçantes, encountered a mysterious illness affecting local residents. His methodical investigation led to one of medicine's most comprehensive single discoveries, as he identified not only the causative parasite but also its insect vector and the full spectrum of clinical manifestations. This remarkable achievement involved recognizing the connection between household infestations of triatomine bugs, the presence of trypanosomes in these insects, and the development of disease in exposed humans. Chagas's discovery occurred during a period of intense scientific interest in tropical diseases, yet his findings received limited international attention initially. The disease remained largely confined to rural Latin American communities for decades, perceived as a regional problem with minimal global significance. However, subsequent urbanization and international migration have fundamentally altered the epidemiological landscape, transforming Chagas disease from a rural Latin American curiosity into a global health concern affecting North America, Europe, and other regions with significant immigrant populations from endemic areas. The evolution of scientific understanding regarding Chagas disease has revealed the complexity of host-parasite interactions and the multifaceted nature of chronic parasitic infections. Early researchers focused primarily on acute manifestations, but subsequent investigations have illuminated the prolonged course of infection and the devastating consequences of chronic inflammation and immune-mediated tissue damage. Epidemiological patterns and global distribution. Contemporary epidemiological data reveal that Chagas disease remains endemic in 21 Latin American countries, with the highest prevalence rates documented in Bolivia, where infection rates can exceed 20% in certain rural communities. Argentina, Brazil, Paraguay, and Mexico also harbor significant endemic populations, with transmission patterns varying according to local vector species, housing conditions, and socioeconomic factors. The disease burden extends far beyond traditional endemic boundaries due to population migration and international travel. The United States Centers for Disease Control estimates that over 300,000 people living in the United States carry Trypanosoma cruzi infection, primarily immigrants from Latin America and their children. European countries, particularly Spain, Italy, and Switzerland, have documented increasing numbers of cases among Latin American immigrant communities, prompting changes in blood screening protocols and clinical practice guidelines. These demographic shifts have created new challenges for healthcare systems unaccustomed to managing Chagas disease. Many healthcare providers in non-endemic regions lack familiarity with the condition, leading to delayed diagnosis and missed opportunities for early intervention. The globalization of Chagas disease has highlighted disparities in medical education and the need for enhanced awareness among healthcare professionals serving diverse patient populations. The economic impact of Chagas disease extends beyond direct medical costs to encompass lost productivity, disability, and premature mortality. Endemic countries bear substantial economic burdens related to healthcare provision, while receiving countries face challenges in screening immigrant populations and managing chronic complications. These economic considerations underscore the importance of prevention strategies and early intervention programs. Transmission mechanisms and risk factors. Vector-borne transmission remains the primary mechanism of Trypanosoma cruzi infection in endemic regions, involving complex ecological relationships between triatomine insects, mammalian reservoir hosts, and human populations. These insects typically inhabit cracks and crevices in poorly constructed housing, emerging at night to feed on sleeping humans. The transmission process occurs not through the insect bite itself but through subsequent contamination with infected feces, which are deposited near the feeding site and introduced into the wound through scratching or rubbing. Housing quality emerges as the most significant risk factor for vector-borne transmission, with adobe construction, thatched roofing, and inadequate ceiling providing ideal habitats for triatomine colonization. Rural populations living in poverty face the highest transmission risks due to substandard housing conditions and limited access to vector control measures. Children appear particularly vulnerable to infection, possibly due to behavioral factors and immune system immaturity. Alternative transmission routes have gained increasing importance, particularly in non-endemic regions where vector transmission is rare or absent. Congenital transmission from infected mothers to their children represents a growing concern, with transmission rates varying from 1 to 12% depending on maternal parasite burden and other factors. This route of infection has made Chagas disease a pediatric concern in countries far from traditional endemic areas. Blood transfusion historically represented a major transmission mechanism before implementation of universal screening programs. Contemporary transfusion-related transmission has become rare in countries with comprehensive blood supply safety measures, but risk persists in regions with inadequate screening infrastructure. Organ transplantation presents similar risks, particularly given the potential for immunosuppression to reactivate latent infections in both donors and recipients. Oral transmission, while uncommon, has caused several notable outbreaks linked to consumption of contaminated food or beverages. Fresh fruit juices, particularly acai pulp, have been implicated in Brazilian outbreaks, while contaminated beverages have caused clusters in other South American countries. These incidents highlight the potential for foodborne transmission and the importance of food safety measures in endemic regions. Pathophysiological mechanisms and disease progression. Chagas disease follows a biphasic course characterized by distinct acute and chronic phases with markedly different clinical presentations and pathophysiological mechanisms. The acute phase typically occurs within weeks of initial infection and involves high levels of parasitemia as Trypanosoma cruzi establishes infection throughout the body. During this period, parasites can be readily detected in peripheral blood, and patients may develop nonspecific symptoms resembling viral infections. The transition from acute to chronic infection involves complex immunological processes that fail to completely eliminate the parasite despite mounting robust immune responses. Trypanosoma cruzi demonstrates remarkable capacity for immune evasion through antigenic variation, tissue sequestration, and molecular mimicry. These mechanisms allow persistent infection despite ongoing immune surveillance, setting the stage for chronic complications. Chronic Chagas disease develops through mechanisms involving both direct parasitic damage and immune-mediated tissue destruction. Persistent inflammation leads to progressive fibrosis and functional impairment in target organs, particularly the heart, esophagus, and colon. The predilection for these specific organs reflects the distribution of parasitic persistence and local inflammatory responses rather than simple parasite burden. Cardiac involvement represents the most severe manifestation of chronic Chagas disease, characterized by progressive cardiomyopathy that can lead to heart failure, arrhythmias, and sudden death. The pathophysiology involves chronic myocarditis with inflammatory cell infiltration, myocyte destruction, and replacement fibrosis. Conduction system involvement frequently produces characteristic electrocardiographic abnormalities, including right bundle branch block and left anterior fascicular block. Gastrointestinal manifestations result from destruction of enteric nervous system components, leading to megaesophagus and megacolon. These complications develop gradually over years or decades, producing progressive dysfunction that can severely impact quality of life. The pathophysiology involves inflammatory destruction of myenteric plexus neurons, resulting in a peristalsis and massive organ dilation. Clinical manifestations across disease phases. The clinical presentation of Chagas disease varies dramatically between acute and chronic phases, creating diagnostic challenges and opportunities for intervention at different stages of infection. Acute Chagas disease often presents with nonspecific symptoms that can easily be mistaken for common viral illnesses, particularly in pediatric populations where most acute infections occur. Romagnol's sign, characterized by unilateral painless periorbital swelling, represents the classical manifestation of acute infection when parasites enter through conjunctival mucosa. This distinctive finding occurs in a minority of acute cases but provides strong diagnostic evidence when present. Alternative entry sites may produce localized inflammatory reactions called chagomas, though these are less commonly recognized. Systemic manifestations of acute infection include fever, malaise, lymphadenopathy, and hepatosplenomegaly. Severe cases can develop myocarditis or meningoencephalitis, particularly in very young children or immunocompromised individuals. Mortality during acute infection ranges from 5 to 10% in pediatric cases, primarily due to cardiac complications or central nervous system involvement. The indeterminate phase follows resolution of acute symptoms and can persist for decades without clinical manifestations. During this period, patients remain asymptomatic despite harboring persistent infection, and routine laboratory tests typically reveal no abnormalities. However, specialized cardiac testing may detect subclinical abnormalities that predict future complications. Chronic Chagas disease eventually develops in approximately 30 to 40% of infected individuals, typically manifesting 10 to 30 years after initial infection. Cardiac disease represents the most common and severe chronic manifestation, presenting with heart failure symptoms, arrhythmias, or sudden death. The progression from asymptomatic infection to symptomatic heart disease can be gradual or precipitous, making regular monitoring essential for infected individuals. Gastrointestinal complications produce distinct clinical syndromes depending on the affected organ. Megaesophagus causes progressive dysphagia, regurgitation, and aspiration risk, while megacolon produces severe constipation that can progress to intestinal obstruction. These complications significantly impact nutritional status and quality of life while creating risks for serious secondary complications. Diagnostic approaches and laboratory methods. Accurate diagnosis of Chagas disease requires understanding of the relationship between disease phase, diagnostic methods, and clinical presentations. Acute infection allows direct parasitological diagnosis through microscopic examination of fresh blood preparations or concentration techniques that reveal motile trypanosomes. These methods provide definitive evidence of infection but require immediate specimen processing and experienced laboratory personnel. Polymerase chain reaction testing offers enhanced sensitivity for detecting parasitic DNA during acute infection and can remain positive during early chronic infection. However, PCR methods lack standardization across laboratories, and negative results do not exclude infection. Contemporary molecular techniques show promise for improving diagnostic accuracy, but implementation requires significant laboratory infrastructure and technical expertise. Chronic infection diagnosis relies primarily on serological testing to detect antibodies against Trypanosoma cruzi antigens. Multiple testing methods exist, including enzyme-linked immunosorbent assays, indirect immunofluorescence, and immunoblot techniques. The diversity of available tests reflects ongoing efforts to improve diagnostic accuracy while addressing cross-reactivity concerns with related parasites. International guidelines recommend using 2 different serological methods for chronic infection diagnosis, as no single test achieves perfect sensitivity and specificity. Discordant results require additional testing or clinical correlation to establish definitive diagnosis. This approach helps minimize both false positive and false negative results but can complicate clinical decision-making. Specialized testing may be required to evaluate organ involvement and disease severity in diagnosed patients. Electrocardiography can reveal characteristic conduction abnormalities, while echocardiography assesses cardiac structure and function. Gastrointestinal evaluation may include barium studies or endoscopic examination to assess for megaesophagus or megacolon. Treatment strategies and therapeutic limitations. Current treatment options for Chagas disease remain limited to 2 antiparasitic medications, benznidazole and nifurtimox. Both drugs were developed decades ago and suffer from significant limitations including prolonged treatment courses, frequent adverse effects, and uncertain efficacy in chronic infection. Despite these limitations, early treatment can prevent disease progression and reduce transmission risk. Benznidazole represents the preferred first-line therapy based on superior tolerability compared to nifurtimox, though both medications require 60-day treatment courses. Efficacy varies dramatically with patient age and disease phase, with cure rates approaching 80% in acute infection and early chronic infection in children. Adult chronic infection shows lower cure rates, though treatment may still provide clinical benefits by reducing parasite burden and slowing disease progression. Treatment tolerance presents significant challenges, particularly in adult patients who may experience dose-limiting adverse effects. Common side effects include skin rashes, peripheral neuropathy, gastrointestinal disturbances, and hepatotoxicity. These reactions often necessitate treatment interruption or discontinuation, limiting therapeutic success. Careful monitoring and supportive management can improve treatment completion rates. Contraindications to antiparasitic therapy include pregnancy, breastfeeding, and severe kidney or liver disease. These restrictions limit treatment options for important patient populations and highlight the need for safer therapeutic alternatives. Research into alternative treatment regimens and novel therapeutic targets continues, but progress has been slow. Symptomatic management of chronic complications requires specialized medical care and may include cardiac medications, pacemaker implantation, or surgical interventions. Heart failure management follows standard protocols but may require heart transplantation in advanced cases. Gastrointestinal complications may benefit from dietary modifications, medications to improve motility, or surgical procedures including organ resection. Prevention and control strategies comprehensive. Chagas disease prevention requires multifaceted approaches addressing vector control, transmission interruption, and case management. Vector control represents the primary prevention strategy in endemic regions, involving household insecticide application, housing improvements, and community education programs. These interventions have achieved remarkable success in several countries through sustained political commitment and international cooperation. The Southern Cone Initiative, launched in 1991, exemplifies successful regional cooperation in Chagas disease control. This multinational effort has achieved virtual elimination of household vector infestations in Uruguay and Chile while dramatically reducing transmission in Brazil and Argentina. Success required coordinated efforts involving entomological surveillance, targeted insecticide applications, and housing improvements. Housing improvement programs address the fundamental environmental factors that enable vector colonization. Replacing adobe walls with brick construction, improving roof design, and sealing cracks and crevices can eliminate triatomine habitats and prevent re-infestation. These interventions require significant investment but provide lasting protection against vector-borne transmission. Blood supply safety measures have successfully prevented transfusion-related transmission in most countries with adequate screening infrastructure. Universal donor screening using sensitive serological tests has rendered transfusion transmission extremely rare in developed countries. However, implementation challenges persist in resource-limited settings where blood safety infrastructure may be inadequate. Congenital transmission prevention requires identifying infected women of reproductive age and providing appropriate counseling and treatment. Screening pregnant women from endemic regions can identify at-risk pregnancies and enable early diagnosis and treatment of infected infants. These programs require integration of Chagas disease screening into routine maternal and child health services. Research frontiers and future directions. Contemporary Chagas disease research encompasses drug development, vaccine research, diagnostic innovation, and epidemiological investigation. Novel therapeutic approaches under investigation include shorter treatment courses, combination therapies, and drugs targeting different parasitic pathways. However, drug development faces significant challenges including limited commercial incentives and complex regulatory requirements. Recent clinical trials have evaluated drugs initially developed for other indications, including posaconazole and E1224. While these trials demonstrated safety and initial efficacy, sustained parasitological cure remained elusive. These disappointing results highlight the challenges of developing effective therapies for chronic parasitic infections and the need for innovative approaches. Vaccine development represents a promising long-term strategy for Chagas disease prevention, though no vaccines have reached clinical application. Research efforts focus on DNA-based vaccines, recombinant protein formulations, and live-attenuated parasites. The goal involves preventing infection or reducing disease severity rather than achieving complete protection, given the complex immunology of chronic parasitic infections. Diagnostic innovation aims to develop rapid, point-of-care tests suitable for use in resource-limited settings. Current serological tests require laboratory infrastructure and trained personnel, limiting their utility in rural endemic areas. Rapid diagnostic tests could enable screening programs and improve case detection in underserved populations. Genomic research is providing new insights into parasite diversity, host susceptibility factors, and drug resistance mechanisms. Understanding genetic factors that influence disease progression could enable personalized treatment approaches and identify individuals at highest risk for severe complications. These advances may eventually enable precision medicine approaches to Chagas disease management. Socioeconomic dimensions and health equity. Chagas disease epitomizes the concept of diseases of poverty, disproportionately affecting marginalized populations with limited access to healthcare, adequate housing, and economic opportunities. The disease perpetuates cycles of poverty through chronic illness, disability, and premature mortality while requiring expensive medical interventions that further burden affected families and communities. Rural indigenous populations in Latin America face particularly high infection rates due to traditional housing practices, limited healthcare access, and ongoing exposure to zoonotic transmission cycles. These populations often lack political representation and advocacy, contributing to the neglect of Chagas disease in public health priorities. Addressing these disparities requires culturally appropriate interventions and meaningful community engagement. Urban migration has created new epidemiological patterns as infected individuals move to cities seeking economic opportunities. Urban slums may harbor vector populations while lacking adequate healthcare infrastructure, creating conditions for continued transmission and limited access to diagnosis and treatment. These dynamics highlight the intersection between urbanization, poverty, and infectious disease transmission. International migration has globalized Chagas disease, creating new challenges for healthcare systems in receiving countries. Many immigrants from endemic regions remain undiagnosed due to lack of awareness among healthcare providers and barriers to healthcare access. These populations may face additional challenges including language barriers, documentation status concerns, and cultural differences in health-seeking behavior. Global health implications and policy responses. The inclusion of Chagas disease among the World Health Organization's neglected tropical diseases reflects recognition of its global significance and the inadequacy of current control efforts. This designation has increased political attention and research funding while highlighting the need for sustained international cooperation and resource allocation. Blood safety initiatives have achieved success in preventing transfusion-related transmission through implementation of universal screening programs. However, these successes required significant investment in laboratory infrastructure and quality assurance systems that remain challenging to implement in resource-limited settings. Technical assistance and financial support from international organizations have been crucial for expanding blood safety measures. International migration policies and health services integration present ongoing challenges for addressing Chagas disease in non-endemic countries. Healthcare systems must adapt to serve populations at risk while training providers to recognize and manage unfamiliar conditions. These adaptations require investment in provider education, diagnostic capabilities, and care coordination systems. Research and development policies have historically neglected diseases affecting primarily poor populations in developing countries. Recent initiatives including product development partnerships and advanced market commitments have begun to address these market failures, but sustained commitment and innovative financing mechanisms remain necessary to accelerate progress. Contemporary challenges and future outlook. Despite significant progress in vector control and blood safety, Chagas disease remains a formidable global health challenge requiring sustained attention and resource allocation. Climate change may alter vector distribution patterns while population growth and urbanization create new transmission scenarios. These evolving dynamics require adaptive surveillance and control strategies. Drug development continues to face significant obstacles including limited commercial incentives, complex regulatory pathways, and the challenges of conducting clinical trials in diverse populations across multiple countries. Public-private partnerships and innovative financing mechanisms may help overcome these barriers, but progress has been disappointingly slow. Healthcare systems strengthening in endemic regions remains crucial for improving case detection, treatment access, and chronic disease management. These efforts require sustained political commitment and international support while addressing broader determinants of health including poverty, education, and housing quality. The globalization of Chagas disease creates opportunities for increased research collaboration and resource mobilization while presenting challenges for healthcare systems unaccustomed to managing tropical diseases. Success requires coordinated international responses that address both endemic and non-endemic country needs while maintaining focus on the populations most severely affected by this neglected disease. The path forward for Chagas disease control requires sustained commitment to comprehensive approaches that combine vector control, case management, research innovation, and social determinant interventions. Only through such coordinated efforts can the global community hope to reduce the burden of this ancient disease and prevent its continued spread in an interconnected world.